Today, I'm going to talk to you about the potential of managing traumatic injuries as chronic conditions. This work has been supported by a grant from the National Institute on Disability, Independent Living, and Rehabilitation Research. It's important to realize that chronic conditions can emerge from illnesses such as brain injury, spinal cord injury, burn injury, as just examples. So these chronic conditions in and of themselves, from the direct injury or subsequent consequences, can have a range of effects, from impacting limited function and participation, difficulties with employment, and then, of course, financial burden on the person and their family, and then the healthcare system and society, an impact on fitness. These injuries may also contribute to, down the road, additional comorbid health conditions. And then you can see how this would impact health, hospitalization, and even early mortality, and overall an impact on quality of life. So really important that we try to figure out how to get the best outcomes for chronic conditions after injuries. And our current infrastructure for managing injuries in the long term really is not set up for that. So we have a lot of infrastructure in regards to resuscitation and early care, maybe early rehabilitation. And then a lot of people experience a lack of resources, a lack of structure. I like to picture this with, we've built the bridge part of the way, but we don't have that bridge in place for the long-term living with after injury. Over the past several decades, in the United States, we've learned that by using chronic care models that we can actually improve the health cost and healthcare utilization from chronic diseases. So diseases like diabetes, cardiac conditions, asthma, renal disease, there are several diseases for which healthcare funding, CMS, Medicare, and private insurance companies have realized if we can put these chronic disease models in place, we can actually get these better outcomes and at reduced cost. What we don't know is if these models could help with managing chronic injury, and we suspect that it could help, and a lot of structure would be needed to do so that is not currently in place. Some models exist for this: the collaborative care model and the integrative care or chronic care model, first proposed by Wagner. So I'm going to talk about both of those models today, just as examples of how a chronic disease model is used to improve outcome. Common elements of chronic disease models. So these different models have various different structures and components, but in general, they're evidence-based. They entail screening for different conditions, entail a comprehensive workup and surveillance with clear treatment priorities and goals, written plans of care, and that the care is driven by protocols and stepped stage by stage for what the person needs at that point in time, and with very active and defined follow-up periods, and who will do that follow-up with very specific target measures and what to do in adjustment depending on what the target measures show, assessment of how well there's adherence to the treatments that have been put in place through these models. Really important piece is consideration of the patient's goals and their values, and then tailoring education based on what the patient's needs and abilities are. Supported self-management, which I'll talk about, collaborative care itself, either as a model or sometimes pieces of it integrated, and the ability to risk stratify. So just an example of the importance of risk stratification. So not everybody needs the really high intense aspects of care management. So most people, 70 to 80% of people experiencing a chronic condition are at low risk and can manage with self-care and some supported self-management, whereas there's kind of that middle portion that needs some disease management. And then the higher risk someone is, the more intense needs they have, and perhaps might even require case management to get the best outcomes. I'm going to give you some examples of collaborative care. So that was one of the models I mentioned. The figures I have here are taken from the University of Washington's programs. They have used this for multiple sclerosis and in spinal cord. Collaborative care, basically, you've got the tradition of the patient and the physicians and nurses working hand in hand. In this example, it's for spinal cord injury, physicians and nurses working with the patient. And the patient is given treatment choices. And then the unique piece here is that a collaborative case manager works with the patient and then gives feedback to the physicians and nurses. And then in addition to that, there's experts in whatever aspect we're trying to help this person, this model with. So for in this example, there's experts in pain, physical activity, and depression, who then work with the care manager and the physicians to try to help the team know how to manage things with the patient. And the collaborative care manager is going back and forth with the patient to facilitate this care coordination. And then also the care manager is working with the patient to assess adherence and treatment response, and then again, give that information back to the experts and the other physician and nurses. And generally there's regular case management to where the team gets to discuss and move to the next level of care that's needed. And so you can see this is aimed at getting, in this example, treating pain, with treating the pain, getting people more active, less depressed, and improving quality of life. The next example is the integrated care model, or the chronic care model, first proposed by Wagner. This has components in the healthcare system as well as the community. And you see here delivery system, decision support, clinical information systems, and self-management are the aspects in the health systems, whereas the pieces in the community are a supportive environment and using public policy and resources to improve the community in which someone's living with a chronic illness. As an example, for the delivery system, we're talking about case management based on risk, that the plan is based on risk, and you've got a clinical team in place with the expertise needed. Whereas decision support is evidence-based guidelines, seminars, consultation, like that collaborative care with various experts in that area, where clinical information systems is having a registry in place that can prompt the care needs and performance metrics for information to get back to the clinicians. And then supported self-management, which I'll talk about in a little bit, is working with the person with the injury to help them achieve goals, supportive environment, and the public policy and resources. In 2018, there was a systematic review of integrated care models with 157 studies reviewed. Most of these studies showed an improvement in both professional and patient outcomes. And what they also did is they quantified in all these different 157 papers to which aspects of the chronic care model were being integrated. So oftentimes with these chronic care models, it's not every piece of this in place. And what they found is the most common element integrated into these care models is self-management, almost 50%, and followed by delivery system design and decision support, and less so the clinical information and the healthcare delivery system. What you'll see very little is the use of community resources being applied to improve the health and function for people with a chronic condition. So just a little bit on self-management, since that is a really important piece that can be used for that 70 to 80% at risk and is the most common piece of chronic integrative care that is utilized. This has been well defined by Kate Lorig. Dr. Lorig. The importance of self-management is people with disability and chronic injury, chronic illness have very little time in front of healthcare professionals. It's read an article that on average, there's 3 hours a year that someone with disability spends with a healthcare professional. And the average visit with a physician is 13 to 24 minutes. So you can see with that little bit of healthcare professional time that really we need to have an infrastructure in place where people with injury or illness are themselves activated, empowered, and have the self-efficacy to be able to manage their condition within their environment and the supports that they have. So it's a very intensive, individualized treatment, and it's conducted away from the healthcare contacts, but with support. So for example, there may be support in regards to the activation and structure, and someone helping with defining and redefining goals. This needs to be something that is a patient perceived problem, because they're going to be the ones self-managing. It is accomplished through goal attainment, vicarious experiences, verbal persuasion, and activities linked to their status. And this is accomplished through education, activation, goal setting, goal support, and developing action plans to help promote healthy activities, and also involves self-monitoring. So, that they have a marker of something they can monitor to know that they're making progress. Dr. Lorig describes 6 core skills, including problem solving, decision making, resource utilization, patient-provider partnership, and action planning on their goals, and self-tailoring. Certainly in applying this work for people with brain injury, I think about this often and think there's certainly a few other skills that may be really important to take into consideration. For example, self-awareness, initiation. There are definitely some skills that are required in an environment in which to do supported self-management. There are several examples of self-management that are already in place for other conditions that could be incorporated with brain injury, spinal cord burn, and other chronic injuries, such as self-management for depression, pain, substance use, alcohol use. Diabetes is probably the most common in use, and just chronic illness. So I'm going to show you what we're doing for brain injury and managing it as a chronic condition as an example of what could be done. So first, we realize the importance of this. Brain injury, we have realized, is a chronic condition. It is dynamic. People change in their functional level over time. Our data from the TBI model systems data set have shown us that from epoch to epoch that people are changing. They're either improving or they're declining, or they might do a combination over time. This figure here shows you a comparison using the TBI model systems data set of year 1 to year 2, year 2 to year 5, year 5 to year 10, year 10 to 15, year 15 to 20, 25 to 20 to 25, and 25 to 30. And this is cross-sectional data. And what we found is it was more likely than not that someone would change at least one Glasgow outcome scale extended score level. It's an 8-item measure. 41 to 49% did not change, whereas 16 to 29% experienced improvement. 23 to 37% had some kind of decline. To interpret these tables, the blue is no change at all. The light color is a change by 1 point, and the dark color is a change by 2 points. The pink reddish is decline, and the green is improvement. So with knowing that, we also are thinking, okay, well, what is the care in place to manage people with a chronic condition? And we are definitely not there with brain injury, as well as other many injury conditions such as spinal cord and burn. For brain injury, I know we have sparse data to guide the care, although what we've been learning for the TBI model systems has definitely made it clear that we have data to tell us that people have a chronic condition and it's dynamic. There's a lack of access. There's a lack of connection that if someone ever had a brain injury to begin with, and then also that there might be dynamic chronic effects. There's a lack of providers who have experience with brain injury, and even a lack of infrastructure and money to have the care in place that's needed. There's a lot of misinformation among the general public, healthcare providers, as well as people living with injury in regards to their potential outcome. And those that misinformation is leading to beliefs that are limiting what is offered to people and therefore limiting their outcomes. There's inconsistent approaches from one person to the next in regards to the care that someone might get and the approach to care, and a lack of protocols that we would all use to get more consistent care. We tend to be very reactive in the patient has a problem, and then we do different things as opposed to having surveillance in place at certain epochs and having it more risk-based. And we tend to have a fractured care where there's not a lot of connection with the different care providers to make sure that we're all on the same page with communication. We tend to not use self-management and case management. In large part, though, there is some case management depending on insurer, and we have a lack of measures and markers being utilized to guide the care. And again, also unrecognition that the symptoms someone might be having could be connected to brain injury. So with all this, in 2012, the Galveston Brain Injury Conference established a vision for brain injury as a chronic condition. This is that brain injury will be identified and proactively managed as a lifelong chronic disease that will result in improvements in longevity, level of disability, expense to society, and quality of life. And this will be achieved through modification of our medical and psychosocial healthcare delivery systems, healthcare education curriculum, research agenda, and legislative healthcare policy. So that's a big vision to move us forward. NIDLR, with this recognition, has funded a grant that I'm the principal investigator on. It's called Be Healthy. We are in year 3 of that grant at this moment. The goal of this grant is to develop a chronic disease model for traumatic brain injury with the long-term goal of decreased mortality, improved health function, and quality of life for people with traumatic brain injury. You can see on the right-hand side a figure that details what we're doing. We did evidence-based literature reviews, and now we've designed the components of this model and are conducting feasibility studies to test out different aspects of the model. And then we will move to integrating those results and then moving further with pragmatic trials and consumer advocacy and finding ways to integrate this into policy and community. With the information you just learned about chronic care, that'll come in here in regards to how we're envisioning this model for Be Healthy. We're envisioning as patient-oriented and self-directed. It's a very important piece that it's not just a medical model. So we decided to start with the chronic care model and then add a person-centered approach and use a multidisciplinary program structure as the delivery system. This multidisciplinary program structure we've defined as someone with brain injury medicine expertise, someone with expertise in affect, behavior, and cognition. We're purposely not necessarily putting labels to the different type of person here. For example, not saying it has to be PM and physical medicine rehabilitation, not saying it has to be neuropsychologist, so trying to more describe the type of expertise that is needed. Someone with expertise in movement and exercise, someone with expertise in social and vocational engagement, and community resource navigation. Very important that we engage this supportive environment. And then care coordination to help both within the Be Healthy infrastructure and with other providers. So I mentioned the importance of risk stratification. So we've also built, we'll be building that piece in. We're envisioning engaging risk or intensity of the services based on medical complexity, independence, ability, and self-management, and the community resources that someone has to be able to manage their condition. We've identified 4 core principles and 9 components, which I will review. First is that we want prepared, proactive providers. informed, activated, and supported people with traumatic brain injury and their caregivers, activated communities and prepared proactive community partners, and lastly, a person-centered and culturally humble approach. The Be Healthy will incorporate 9 components: education and support of the participant and caregiver, to identify and treat emotional and behavioral dysfunction, as well as address potential hazardous activities, to reduce potential iatrogenic harm, such as medications that might be hindering recovery, prescribe traumatic brain injury appropriate treatments to augment function and recovery, so rehabilitation and other types of treatments that may help improve someone's function, facilitate social and intellectual engagement, encourage healthy brain behaviors, review for comorbid health conditions and medications that may influence someone's cognitive health or cause excess disability, facilitate with their other providers, and evaluate community barriers and opportunities that could be addressed to improve outcomes. So in summary, we have Be Healthy as an example of what can be done to manage chronic injury, to improve outcomes. For us in Be Healthy, our next steps are to conduct these feasibility projects that we're doing and integrate the results of that into the model that we've developed. We will be developing the protocols and procedures and risk stratification. So all of that needs more meat on the bones to be able to then be able to implement. We're starting to work on plans for sustainability, figuring out aspects of how this model would be funded, planning for a pragmatic trial as a next step, and talking with consumers and other stakeholders to try to think through implications of implementation and ways to implement and identify barriers to be able to integrate. And then, of course, lastly, in doing all of this, we'll be needing to establish return on investment and solid payment mechanisms for success. Thank you very much.